Pansy, the answer dog, just had her breakfast, so she's all excited about picking up where we left off. We're going to finish the Camtasia on the PowerPoint for the bones. Bones are not only the word bones is Pansy's favorite word, and it also happens to be her favorite thing to play with. Oh my God. So here we go. Hope everybody enjoys this. So our pelvic pectoral girdle is formed by two bones. It is formed by the clavicle and the scapula. You'll recall that the scapula was sort of an unusual looking bone because it was very flat, and we determined that the advantage of that flat shape was, in this case, for muscle attachment. So muscles and bones hold these, muscles and ligaments hold these bones in place. Boy, it's been a tough morning. I'm just getting started. That's crazy, right? So here is the clavicle, and it's going to articulate proximally with the manubrium, and distally it's going to articulate with the acromion process of the scapula. If you were writing these things in on an exam, it would be good, for example, to say it articulates with the acromion process of the scapula and not just the acromion process. You want to be complete with your answers. It's going to be a brace in humans for the shoulder, and that allows us to use our upper limb as a tool. We find a lot of animals, cats, we talked about cheetahs and stuff, they actually do not have an articulation with the clavicle, which gives them a shoulder that can move freely a lot more than ours. Ours is quite restricted actually because of that, but it does have an advantage. Wow, did you see that thing bounce in? So there's the scapula on each side. Remember that we talked about the flat shape being advantageous for muscle attachment, and articulates with the clavicle distally. It also articulates with the head of the humerus, and that's going to be in the glenoid cavity. So there's the acromion process that articulates with the clavicle. We have the coracoid process. Coracoid process forms because three muscles attach to it: the pectoralis minor, coracobrachialis, and the short head of biceps brachii. And then we have the glenoid cavity. Glenoid cavity, as I mentioned, is going to be where the head of the humerus articulates. Here we see from the posterior view the acromion process and the spine. The spine of the scapula is an important landmark. As you might imagine, this is where muscles attach, so both the trapezius and the deltoid muscles attach there. Also, both of those muscles attach to the acromion process as well. In the arm, we only have one bone. That'll be the humerus. And there it is. Oh my gosh, these guys are flipping all around today. Very entertaining. So there's the head that articulates with the glenoid cavity of the scapula. We have the deltoid tuberosity, just slightly proximal to the midpoint of the humerus. And the deltoid tuberosity, as you might expect, would be where, well, Pansy, you can tell me what attaches there. Right, the deltoid muscle. She's so smart. We have a coronoid fossa, and the coronoid fossa is going to be on the anterior side. Yes, on the anterior side. Boy, this is a tough morning. And the coronoid process of the ulna inserts into that depression when you flex your forearm. We have the capitulum, and the capitulum is where the head of the radius articulates. And if you translate capitulum, it means little head. We also have the trochlea, and the trochlea is going to articulate with the trochlear notch of the ulna. And again, this is an anterior view. Here we have the posterior view. We have the greater tubercle. We have the olecranon fossa. Olecranon fossa is where the olecranon process of the ulna inserts when your forearm's extended. And then we have the bicipital or intertubercular groove. This is where the bicipital tendon from the biceps brachii runs through that slot and then up to the supraglenoid tubercle of the scapula. We have the lesser tubercle. Okay. And then the forearm, we're going to have two bones. Laterally, we're going to have the radius, and medially, we're going to have the ulna. Okay, so there's the radius laterally, right, anatomical position. This is the palm of this person's hand, right, and then the ulna is medial to the radius. So the radius is lateral, ulna is medial, and in the anatomical position these bones are parallel, and your hand would be supinated. In a cat, the anatomical position has them forming an X, and the palm of the hand would be, well, the palm of the paw would be touching the ground. So they do make an X when they're pronated. So here's the radius. We're looking at an anterior view of the radius. There's the head and the bicipital or radial tuberosity. That's where one of the tendons from the biceps brachii inserts. And we have the styloid process. Styloid process is going to be lateral. It's down near your thumb. And we have the ulnar notch. And the ulnar notch is where the head of the ulna articulates at the distal end of the forearm. That actually is a joint that allows for pivoting and rotation of the radius around the ulna. We have the olecranon process of the ulna. That's going to insert into the olecranon fossa of the humerus. We have the trochlear or semilunar notch. I would go with trochlear notch if I were you, because the trochlear notch then articulates with the trochlea of the humerus. We have the coronoid process, and you remember there was a coronoid fossa on the anterior side of the humerus, so when your forearm is flexed, that inserts into that depression. We have the radial notch, and the radial notch is going to be on the lateral side of the ulna, and that's where the head of the radius articulates, and again that is a pivot joint and allows for rotation of the radius. Here on the posterior side we can see the head of the ulna is distal while the head of the radius is proximal, and we have the styloid process of the ulna, and you can feel that on the posterior side of your wrist on the medial portion of it. In the digits we have phalanges. There are distal phalanges, intermediate phalanges. Notice that the thumb does not have an intermediate phalange. Proximal phalanges, and then we have the metacarpals. The metacarpals are in the portion of your hand that's sort of solid, and you can't actually see these evidence of these individual bones if you're just relaxed. And then we have the carpals, and we have a mnemonic for the carpals, which we'll work on in a little bit here, I suspect. Pisiform is one of the carpals. It's a sesamoid bone. There are two sesamoid bones that we're going to study. One is the pisiform, and the other is the patella. Patella is sometimes called the kneecap in kindergarten. And these two bones are not there when you're born. They develop out of tendons when you grow older. They become bony. They both have two advantages. One is that they move the tendon away from the joint and they reduce friction by doing that, and the other is that by removing the tendon away from the joint they make you stronger. The disadvantage for both of them is that they also slow you down. So we'll be kind of reviewing that. Whenever you get speed you lose power, whenever you get power you lose speed. It's kind of a trade-off. Thumb only has two phalanges, as I mentioned. The other digits all have three. Okay. There's a flexor retinaculum. The flexor retinaculum, sometimes called a carpal ligament, goes across the anterior side of the wrist, and that is involved in the problem that people have when they have carpal tunnel syndrome. Okay. So it forms the roof of the carpal tunnel, and the nerve that gets affected during carpal tunnel syndrome is the median nerve. It runs deep to that ligament. Okay. Carpal tunnel syndrome can be quite painful. They can sometimes treat it, if they get it early enough, by trying to put the person in a brace and stretch the ligament out to reduce the tension and pressure that is exerting on the carpal tunnel itself. If that's not successful, they can make little cuts in the ligament to weaken it so that it stretches a little more. Okay. On each side, there are going to be three bones forming the pelvic girdle, and that's not the upper limb, that's the lower limb. The superior of these bones is the ilium. Whoop, there we go. Look at that thing flipping. Oh my goodness, he's bouncing today. The ilium is superior. Notice it's ILIUM. And then we have the ischium. Ischium is inferior. Ischium is down here. Actually, ilium goes from about right here to about right here. Okay, so this is ilium up here. Ischium goes from about here down to about here. And then the last one is the pubis, and the pubis goes from about here, about here to about there. Okay. So pelvic girdles, sometimes called the os coxa, which means bony hip. And they articulate anteriorly at the pubic symphysis. That would be the two pubic bones would articulate there. And posteriorly, they articulate with the auricular or articular surface of the sacrum. Sometimes it's called a sacroiliac articulation. Pelvis going to be formed from the left and right os coxa. Those are lateral, and the sacrum posteriorly. And then inferiorly we have the coccyx. The coccyx is going to curve a little bit, and so not only is it a posterior border, but it forms part of a shelf to help reduce the risk of having your organs prolapse. Okay, the functions. It's going to transfer weight to the lower limbs. That's pretty important. And if you remember, we talked about the positioning of the lumbar curve so that it's directly over the lower limbs. It's going to articulate with the lower limbs. The acetabulum forms a ball and socket joint with the head of the femur, and the acetabulum actually incorporates all three bones. And the pelvis also protects pelvic organs. The female reproductive organs are within the pelvis. Urinary bladder, at least in part, is within the pelvis, and part of the large intestine, mostly the rectum and anal canal. So here we have some colors to show you the three bones: ilium, ischium, and pubis. And if you were to look at a real os coxa, you'd see right in here there would be sort of a roughness. That's where the ischium, the pubis and the ilium connect. Right here there would be another area that's kind of rough, and that would be between the pubis and the ischium. And then posteriorly here, that's where the ischium and ilium meet. Here are a couple more drawings. There's the ilium, ischium, and pubis. So there are a number of landmarks that you should be aware of. We have the iliac crest. The iliac crest is sort of shaped like a runner of a rocking chair. Okay, here's the anterior portion and posterior portion. And this turns out to be a really important landmark because a lot of muscles attach to the iliac crest. The anterior superior iliac spine, sometimes called the ASIS, I would not use that. I would go with the words so you know what the words are. That's going to be the anterior-most portion or point of the iliac crest. We have the PSIS, posterior superior iliac spine. That's the posterior extent of the iliac crest. And actually, if you look at a person who is naked, I don't know if any of you have ever seen this before. If not, this is something to look forward to. But you'll see on the posterior side there'll be two little dimples, and those are the posterior superior iliac spines. We have the greater sciatic notch. Okay. And the ilium is going to articulate with the sacrum at the auricular or articular surface. We have the ischial spine. That's part of the ischium. We have the ischial tuberosity. Now, you actually sit on your ischial tuberosity. A lot of people think, talk about sitting on your gluteus maximus, but actually the pressure that's brought to bear comes down on the ischial tuberosity. There you go. Then here's the acetabulum. Acetabulum means little vinegar cup, and that is where the head of the femur articulates. There are going to be all three bones meeting there. Then the obturator foramen. The obturator foramen is an opening. A lot of people are kind of surprised there's an opening there, but there are a number of structures that pass through there. And then the pubic symphysis. Pubic symphysis on the anterior surface of the pubic bone, where these two bones meet in an amphiarthrosis or a symphysis joint. If we were to do a coronal cut through the pelvis, we would see that the true pelvis is down in this area. This is referred to as the false pelvis, and it's really the inferior end of your abdominal cavity. And I should mention, a lot of people combine the abdominal and pelvic cavities, so because there is no anatomical barrier, so they refer to an abdominal pelvic cavity, and I think that's really good. You can make a pretty good argument for that. We're going to keep them separate just for study purposes, but it is an artificial separation. The pelvic brim is where the pelvis begins, or pelvic inlet, and here it looks as though it's flat. In fact, the pelvic brim is at about a 60-degree angle to the horizontal. True pelvis is inferior to that pelvic brim. And then we have the pelvic outlet. Pelvic outlet, unlike the pelvic brim or pelvic inlet, is not flat. It's got a little bit of curve to it, sort of shaped like a shallow bowl. And you want to remember that when a woman is giving birth to her baby, if it's going through the birth canal, it has to pass through that pelvic outlet. And you'll see that that's not really a very large opening. Now here we can distinguish males from females. Here we have a male pelvis, and here we have a female pelvis. And the biggest difference from the anterior side is this angle. Usually this angle is about 50 to 60 degrees, whereas in a female it's closer to 80 or 85 degrees, almost 90 degrees. And this change comes about with puberty. And the benefit of having this broaden is it is easier to have babies. The disadvantage is that it can affect the knee and how the lower appendage supports the body. Okay, so the good news is having babies, and the bad news is the knees. The knees definitely suffer in some women. I should also mention that not all women undergo this change. So this can be sort of, it's not everybody has that. Okay, so male and prepubescent female cavities, they're pretty much the same. There's a heart-shaped pelvic inlet, a narrow pelvic outlet, the funnel-shaped pelvic cavity, and a narrow pubic arch, 50 to 60 degrees, as I mentioned earlier. So here we see the pelvic inlet, and you'll notice it's almost heart-shaped, which has led a number of people to erroneously conclude that a male's heart is in his pelvis. We have the narrow pelvic outlet, funnel-shaped pelvic cavity, 50 to 60 degree pubic arch. For post-pubescent females, not all but most, we have some changes. One is that the pelvic inlet becomes a wide oval. The pelvic outlet is round. The walls of the pelvic cavity are shaped like a cylinder, and the pubic arch is 80 to 85 degrees. It is almost 90 degrees wide. So when we look at that, here we see there's the pelvic inlet, kind of a broad oval, round outlet, cylindrical walls. And this last picture, really I should redraw this. This is one of Dr. Zanella's drawings. It is not a curve like this. It's quite angular, but it is between 80 and 85 degrees. Okay, lower limb. Lower limb is going to include the thigh, the patella or kneecap, the leg, the foot, and in the thigh there's going to be just one bone, and that will be the femur. Okay, there's the femur. Oh my goodness. And the femur is one of the most difficult bones in the body to break. It is a very robust and stable bone. Here we see both anterior and posterior views of a right femur. Okay, there's the anterior, there's posterior. So we have the medial epicondyle and the medial condyle. The medial condyle is going to articulate with the medial condyle of the tibia. And we have the lateral epicondyle and the lateral condyle. The lateral condyle is going to articulate with the lateral condyle of the tibia. We have the head, which articulates with the acetabulum. Greater trochanter. You can see this is really like a super huge tubercle for muscle attachment. We have the lesser trochanter. Lesser trochanter actually is where the iliopsoas muscle attaches. Iliopsoas is the prime flexor of the thigh, so it's kind of a big deal. We have the linea aspera, this long ridge running along the posterior side. Most of the adductor muscles insert on the linea aspera. And then the patellar surface. So the patellar surface is where the patella will articulate with this bone. Okay, so we've got the patella. And as I mentioned, it's a sesamoid bone. So it's not there when you're born. It forms out of the ligament connecting these two bones. And it gives us a mechanical advantage, but that comes as a cost. We lose speed. It's one of those trade-off things. Okay. And the sesamoid bone was actually discovered by, these are actually two of Pansy's favorite anatomists. Right, Bert and Ernie. And Bert and Ernie, famous anatomists who discovered this bone while working in their anatomy lab at Sesamoid Street. Oh my God. She likes that program. Okay, especially the count. There are going to be two bones in the leg. The larger bone is the tibia, and the smaller bone is the fibula. You notice that, wow, there's the tibia. It bears almost all of the weight when you are standing up. The fibula is an accessory. It does help, but it doesn't help a huge amount. Pretty small percentage of the weight transfers to the fibula. So here is the anterior view of a right tibia. We have the medial condyle and the lateral condyle. Those articulate with the medial and lateral condyles of the femur, respectively. We have the tibial tuberosity. That's where the patellar ligament inserts on the tibia. Anterior crest and the medial malleolus. So medial malleolus is the way that and the tibial tuberosity. You know the tibial tuberosity is anterior and the medial malleolus is medial. So if you position the bone that way, it gets to be pretty easy to tell left from right. Posteriorly, we have the medial condyle again, the medial malleolus again. Oh, and that was a right tibia. And here we have the fibula. So there's the head and the lateral malleolus. Lateral malleolus is going to be the lateral side. No, I know you get excited about the fibula. The lateral malleolus is lateral, and you'll notice fibula has an L in it, and lateral has an L in it. So that's how I remember which one has the L. Tibia does not have an L. It's going to stabilize your ankle in terms of its functional importance, and it's going to bear somewhere between 10 and 0% of your weight. So you can break a fibula and you can still get around pretty well. So the fibula has the L and it is lateral. Pansy's very excited about the fibula this morning. Okay. Here are the phalanges. Though similar to the fingers, the big toe only has two, and the other toes have three intermediate. They have the intermediate phalanges and the proximal phalanges. And then we have the metatarsals. Those are the bones of your foot. And we have the tarsals. This is a right foot. There's the talus, sometimes called your ankle bone. Talus looks a little bit like a turtle. You can see that this would be the head of the turtle and this would be its shell. Okay, and the flat side is medial. The lateral side is not flat. Okay, and then we have the calcaneus. Calcaneus is known as your heel bone. Functionally, this is really important because this is where the calcaneal or Achilles tendon inserts in the foot. So talus is going to form a special kind of joint with the tibia and the fibula. It's called a mortise and tenon joint, and it allows for dorsiflexion and plantar flexion, and we do have a little bit of inversion and eversion. Okay. As I mentioned earlier, same thing as with the thumb. The big toe only has two phalanges, the others have three. Big toe and the thumb do not have the intermediate phalanges. So next we're going to spend a little bit of time on joints, and not the kind that many of you are fond of. This is going to be where bones come in contact with each other. And we can classify joints in two ways. We can classify joints in terms of how much movement they allow. We'll start with that one. And so I'm going to use blue letters when we're talking about the amount of movement. We have synostoses or synarthroses. These are joints that provide for no movement at all. They are fixed joints. We have amphiarthroses. Amphiarthroses are going to allow for slight movement. And then we have diarthroses. Diarthroses are sometimes referred to as freely moving joints, or sometimes they're called synovial joints. All synovial joints are diarthroses, and all diarthroses are synovial joints. Okay, so a second way we could classify joints would be based on the material found between the bones. And so there are three kinds in terms of that. We have fibrous joints. There are three types of fibrous joints: sutures, gomphoses, and syndesmoses. And the fibrous joints have fibrous connective tissue that join the bones. We have fibrocartilaginous joints, or sometimes they're referred to as cartilaginous joints. There are two kinds of fibrocartilaginous joints. There are synchondroses or symphyses. The synchondroses are non-movable joints, and the symphyses are amphiarthroses, partially movable joints. The bones are connected by either fibrocartilage or by hyaline cartilage. And then the third kind of joint would be the diarthroses or synovial joints. And the synovial joints have three components. The bones are joined together by a joint capsule, and they all have, as we'll see, articular cartilage, synovial membrane, and the joint capsule. So let's start with some of the fibrous joints. We'll do the sutures first. Sutures eventually are fused and don't move, but they don't start that way. They start as with fibrous periosteum between the bones, and then eventually they develop into a non-movable joint, a synostosis. Fontanelles start out at birth and eventually become sutures. And the fact that they're not fused initially actually is a big deal functionally, because it allows for flexibility during birth, and it also allows the skull to grow. So here we have the coronal suture, and as you might imagine, the coronal suture is in the coronal plane. We have a lambdoidal suture. That's not actually how you say it, but that's how Pansy likes to say it because it helps her spell it. So the lambdoidal suture looks like a lambda, the Greek letter lambda. Capital lambda looks like an upside down V. We have the squamosal suture, which is relatively flat between the parietal bones and the temporal bone. And then we have the sagittal suture, and the sagittal suture separates the two parietal bones. The parietal bones are the only bones that actually contact all four sutures. Here's a tooth and a gomphosis. Gomphosis is the joint between the tooth and the bone that it is embedded within. And these actually are amphiarthroses. So I think most people kind of think of their teeth as not moving and being fairly fixed in position, but in fact they do move a little bit, and we use that movement to kind of monitor how chewing is going. So that's a big deal. So that's on the short term. They have that little bit of movement. On the long term, the teeth actually migrate. It's called mesial drift, and they migrate anteriorly toward the midline. So if you start out as a young person with your permanent teeth and they're all beautifully aligned and nice spaces between them, as you get older and older, the teeth in the anterior portions of your maxillary and mandible, maxillary bones in the mandible start to converge and cross over each other. Syndesmosis occurs in a couple of places. These are fibrous connections between the bones that do not become fixed. The anterior osseous membranes of the wrist, ankle, and the distal tibiofibular joints are all qualified as that. And they stabilize the bones, but they do allow for movement. Now for the fibrocartilaginous joints, we have synchondroses. These start out with the bones being connected by cartilage, but eventually the bones fuse and become solid with respect to each other, and they become a synostosis. There are a bunch of examples of this. The epiphyseal cartilage in long bones, well, all bones actually, and the body So in the epiphyseal cartilage, that becomes bone, and the epiphysis and diaphysis fuse. Body of the sternum starts out as 4 sternebrae with cartilage between them. Eventually they all fuse. The os coxa, remember the os coxa, 3 bones, ilium, ischium, and pubis. They're usually completely fused by about the time you're 26. The sacrum is stabilizing a lot earlier than 26, but it's not completely fused at birth. Rib 1 and the manubrium start out with cartilage between the 2 bones, and then eventually they become fused as well. The epiphyseal cartilage, I mentioned this already, becomes a synostosis. And here's a picture. We have the diaphysis here, and we have the epiphyseal cartilage or epiphyseal plate, a growth plate, and then eventually these all fuse into a single piece. You could also see the spongy bone in that picture. The symphysis. So a symphysis is a fibrocartilaginous joint that does not fuse. It's an amphiarthrosis. It gives some protection and allows for some motion. And in addition to the pubic symphysis, the intervertebral discs, we're going to consider those to be the symphyseal joints or an amphiarthrosis. Just a word about that. So the pubic symphysis, I've never seen anybody claim that it's any kind of a joint other than a symphysis, but a lot of these things are sort of subject to interpretation, and not everybody classifies any given joint the same way. So not every joint is subject to debate, but a lot of them are. A lot of joints are really subject to debate. So what we've done here is try to put together what we consider the most reasonable classification. Pubic symphysis is going to have a little bit of flexibility, and the movement of those bones relative to each other is really important for when you're walking, and therefore you would expect both males and females to have these, and they do. And then also at birth, when a woman is giving birth, the hormones affect this joint, cause it to become less stable, and the additional flexibility allows the baby to be born with less stress. Okay. So here's the pubic symphysis. Again, it's amphiarthrosis. Remember, we're using blue letters when we're talking about the amount of movement. Diarthroses are synovial joints. These are sometimes referred to as joints that allow for free movement. They all have 3 components. I mentioned them earlier, but here we're documenting them. We've got the synovial membrane, which is secretes the synovial fluid. We have the articular cartilage covering the surface where bones will articulate. That's hyaline cartilage, by the way. And I should also mention it's fairly thin. It's not like a big, thick piece of cartilage. And then we have the joint capsule. The joint capsule is going to be dense connective tissue connecting the bones. So the synovial membrane is going to line the joint cavity. It is made out of connective tissue, and this is sort of unusual because it does secrete synovial fluid. And if you remember back when we talked about the functions of the various kinds of tissues, we said that normally if you have secretions, they're coming from epithelial tissue. This is an exception to that, a rather remarkable exception actually. So the synovial fluid is going to lubricate, dissipate heat, and it does allow for a little bit of shock absorption, but I think the key thing there is a little bit, not a huge amount. The articular cartilage is hyaline cartilage. It's kind of rubbery, smooth, and if you lubricate it, it essentially has no friction with the adjacent piece of cartilage that it articulates with. So it reduces friction, helps distribute pressure within the joint. And I think you could argue, since it is a fluid, that it could be a shock absorber. The deal here is, though, that there's not a huge amount of fluid. It's not like the cerebrospinal fluid. And so, yeah, it does shock absorb, but probably not a lot. That's certainly not its major function. The joint capsule. Joint capsule is going to be dense connective tissue. It is an extension of the periosteum of the bones involved in the joint. and it's impermeable, so it helps hold the synovial fluid within the joint. And this is valuable. That's good news and bad news. The bad news is that if you get too much synovial fluid because of an injury, it doesn't leak out, and you get pressure buildup in the joint, and they can restrict the range of motion for the joint. And then it protects the synovial membrane because it's tough. The synovial membrane is not going to be exposed to as much mechanical wear and tear. It can stabilize a joint. In some joints, it forms what's called an extracapsular ligament, which is a thickening of the joint capsule, and it does strengthen the joint and stabilize it. So here we have a diagram. We have the joint capsule, articular cartilage covering the end of the bone, synovial fluid, synovial membrane. This is one of Dr. Zanella's drawings also, and you note that there's a substantial space between these bones. That's not really how it is. In reality, that would be a potential space. The two pieces of cartilage would be pretty much in contact with one another with just a very small amount of synovial fluid between them to lubricate the joint. Here we've added some things in. We've put in a muscle. This particular muscle is going to stabilize the joint. We have a bursa. Bursa is sometimes an extension of the synovial fluid, synovial membrane, and it acts like a bumper between the structures around the joint. Here we have an intracapsular ligament. Not all joints have them, and this one is a double ligament. This would be a drawing of what you have in your knee. You have an anterior cruciform ligament or cruciate ligament, and a posterior cruciform or cruciate ligament. And then we have the tendon, which attaches the bone, obviously. Well, actually attaches the periosteum of the bone. We have the extracapsular ligament. So in this drawing, this extracapsular ligament is a thickening of the joint capsule. So muscles and tendons can stabilize joints, and they do have an advantage over just connective tissue, and that is that they can be exercised and strengthened. And in fact, a lot of times when people go for physical therapy, that's exactly what they're doing. They're giving you exercises to make your muscles stronger to help stabilize joints. The bursa I mentioned before, sometimes it's an extension of the synovial membrane, sometimes it's actually an independent structure. And its function is to prevent abrasion between structures near the joint. It acts like a bumper. Some of you have probably seen a boat or a ship tied to a dock, and they put these bumpers between the dock and the ship to keep the two things from rubbing against each other. If boats or ships rub against the dock, they destroy the dock and they damage the ship or boat. So the bumpers help prevent that, and basically that's what the bursa do, or bursae. Sometimes people get irritation of the bursa. It's called bursitis. If you've ever had it, you know that it can be extremely painful and debilitating. It can be because there's too much pressure in the bursa, which could come from overuse, or it could be because the bursa has dried out and friction has started to occur between the structures. Then we have an intracapsular ligament. We mentioned that already. The example I gave you was the ACL and PCL. So not every joint have these ligaments, but they do stabilize the joint. They hold the bones so that they don't move too much. It does not prevent movement, but they restrict the motion. And the one in the drawing, as I mentioned, is a cruciform ligament of the knee. That's the only place where we have a double ligament, and there's an anterior and posterior ligaments there. So extracapsular ligaments or collateral ligaments, again, not all joints have those. They are also going to stabilize the joint, and they tend to be found on the sides of the joint where motion should not happen. So for example, the knee is a hinge joint functionally. There is a little bit of rotation at extreme extension, but mostly it's just a hinge joint, and so you want the joint to be able to flex and extend, but you do not want abduction, adduction, or rotation. So the extracapsular ligament helps prevent that. In a lot of cases, the extracapsular ligament will actually be fused to the joint capsule. And then sometimes the extracapsular ligaments are actually separate from the joint capsule. And an example of a extracapsular ligament separate from the capsule would be the lateral collateral ligament of the knee. The medial collateral ligament is part of the joint capsule. The lateral collateral ligament is not. So the question then we can ask is, are ligaments or muscles more important for joint stability? And the answer, Pans, right, muscles. Muscles can be strengthened. With ligaments, you kind of have what you have, and if you damage them, actually they're usually never quite as good as they used to be. But with muscles, you can actually do exercises that would strengthen those and then stabilize the joint even more. We have, in some joints, articular meniscuses or semilunar meniscuses or meniscal cartilages. And they have a couple of functions. They stabilize joints. They distribute the force within the joint. And they guide movement. So these are nice things to have. And there are two of them in the knee. And unfortunately, the meniscus cartilage of the knee is one that, or both, may be damaged in exercising or if you twist your knee, and that can lead to a lot of discomfort. Okay, here we have a meniscal cartilage. We have a distal bone. Nancy's decided that this is a boring lecture and she wants to play with a ball. We have the distal bone, we have the articular meniscus, and we have a proximal bone. And you can see how that sort of forms a little cushion between the bones. Now, in terms of types of joints, we'll go through a list. We have saddle joints. As you might expect, a saddle joint looks like a saddle. Exactly. She's so wicked smart. Saddle joints allow for flex, extend, abduct, adduct, and you can circumduct them as well. Couple of examples: the trapezium with the first metacarpal. That's a really good example. If you Indian thumb wrestle, you're using a saddle joint to do that. And then there's also a saddle joint between the sternum and the clavicle. So here is a drawing of a saddle joint. For one of the bones, if you look at it coronally, it's going to look like a depression, a little dip. And then if you look at it from 90 degrees out with a sagittal section, it's going to be convex. So here it's concave and here's convex. Okay. Next we have a ball and socket Toomey joint. Ball and socket Toomey joints, one is going to look like a ball and the other is going to look like a socket. I guess that sort of makes sense, right? This is called a triaxial joint. It allows for flex, extend, abduct, adduct, and rotate, and you can circumduct. There are only two of these on each side of your body, your shoulder and your hip. Next we have pivot joints. So pivot joints are going to allow for rotation, and that's the only motion that you really get. We have several pivot joints. One would be the atlas to the dens. It allows for rotation of the atlas around the dens. One would be the radius to the ulna, both at the proximal and at the distal end. So there's actually two pivot joints in the forearm. Then we have hinge joints. And I believe the hinge joints are the most common joint in the body. They allow for flexion and extension. That's pretty much it. They're rather restrictive. Your knee is a good example. The joints between your phalanges are hinge joints. The trochlea of the humerus to the trochlear notch of the ulna is a hinge joint. And the knee in particular, we depend upon the stability and limited motion in the knee for our safety, really. When you're walking and running, if your knee were to go in other directions, you could end up on the ground and get hurt. So the stability in the knee is really important. We have plane joints or gliding joints. Sometimes they're called sliding joints even. Plane joints typically allow for one kind of motion, although in theory, if you look at one, you would think they would allow for two. Generally, one of the two motions that they might be able to have is prevented by the surrounding structures at the joint. Okay, so the intercarpal joints are plane joints, as are the intertarsal. the clavicle to the acromion is considered a plane joint. And a really good one, the one that I think sort of visually is easiest to relate to, are the articular facets of the vertebrae. They allow for motion in one direction typically. Also the costosternal joints for ribs 2 through 7. Remember that rib 1 becomes fused, and ribs 8 through 10 don't actually articulate directly with the sternum, and 11 and 12 don't articulate anteriorly at all. Condyloid joints, sometimes called shallow ball and socket joint. Condyloid joints are going to allow for flex, extend, abduct, and adduct. And the proximal carpals have condyloid joints with a radius. Metacarpals have condyloid joints with the phalanges. So now we're going to talk about movements, and the movements are not allowed in every joint. You know, we've already talked about the fact that some of them are rather specialized. So we have flexion and extension. Flexion is going to decrease the angle between the bones of the joint, and extension is going to increase the angle between the bones of the joint. So when you are standing in the anatomical position, your forearm is extended, and when you contract your biceps brachii and brachialis, you flex the forearm. Actually, brachioradialis will do that as well. Hyperextension is when you go beyond 180 degrees. So some joints allow for hyperextension, and some joints do not. Just because they extend doesn't mean they hyperextend. So the shoulder is a good example of a joint that allows for hyperextension, and the elbow and the knee are good examples of joints that do not allow for hyperextension in a normal configuration. Now, that is not to say that some people can't hyperextend their elbows or their knees. There are people who can hyperextend their elbows and knees, but generally that leads to destabilization of the joint, so it's not a good thing. We have dorsiflexion and plantar flexion. That's a special case at the ankle. Dorsiflexion would be if you were standing on the ground and you elevate your anterior portion of your foot, and plantar flexion would be if you're standing flat on the ground and you elevate your heel. People who wear high heels plantar flex their foot. Also notice dorsiflex is one word and plantar flex is two. That's one of those things from English. I don't have any explanation for that, but that is the actual spelling. Abduct and adduct. Excuse me. Abduct and adduct can be done with a number of joints that we talked about. Shoulder is a good example. So when you stand in the anatomical position, your upper limb is adducted, and if you were to move it away from your body, that would be abduct. Protract and retract. Protract and retract you can do with a couple of joints. You can protract and retract your mandible. It's not really desirable to do that a lot with that joint because you can irritate the joint and get temporomandibular joint syndrome. But if you have your mouth closed and you move your mandible anteriorly, that's protraction, and if you retract it, you bring it back. We can also do this with the scapula. So if you move your scapula away from the vertebral column, that's protraction, and if you bring it back toward the vertebral column, that's retraction. Rotation. There aren't a lot of joints that truly rotate, but we have a special case of rotation. The shoulder rotates, the hip rotates, and the atlas rotates around the dens. Pronation and supination is a special case in the forearm where the radius rotates around the ulna. Be clear on this, the ulna does not rotate. The ulna flexes and extends, period. That's all it does. It's a true hinge joint. It does not have any kind of rotation occurring with it. The radius, on the other hand, does rotate around the ulna. Circumduction. Circumduction occurs when we form a cone, the surface of a cone with part of our body, and it typically involves a combination, or not typically, it involves a combination of flex, extend, abduct, and adduct. Okay, and we'll talk about that in class. I can demonstrate it better in person than I can describing it, I think. Invert and evert. This is a special case And it's usually used with your feet. If you invert your feet, you bring the soles of your feet toward each other, and if you evert your feet, you bring the soles of your feet away from each other. Elevate and depress. Elevation and depression can also be done with the mandible and the scapula, and in this case, it's not risky. If you elevate your mandible, you close your mouth, and if you depress your mandible, you open your mouth. And a way you might remember that is my lectures, right? So some of you may find it depressing when I open my mouth, so that might help you remember that. Oh my God, Pansy's rolling her eyes. Elevate and depress you can also do with the scapula. So if you hunch your shoulders, for example, when you're really cold, you elevate your shoulders, and when you depress your shoulders, you bring them inferiorly. And so there's a book that I've used in preparing the anatomy and physiology lectures up to this point. That's Matters, and there's some good examples there. Arthritis. Arthritis is the inflammation of a joint, and there are basically two types of arthritis. There's osteoarthritis. This occurs when the articular cartilage deteriorates and you end up with bone rubbing on bone. This can be because of a genetic disorder. It does occur because of genetic disorder. And then we have rheumatoid arthritis. And rheumatoid arthritis, sometimes referred to as RA, that's the inflammation of the synovial membrane because of an autoimmune disease, and your immune system attacks the synovial membrane. The way to treat this one is to administer immune suppressant medications. And the good news is that if you suppress the immune response, then your synovial membrane doesn't get attacked. Bad news is that you're depressing your immune response, and you may have other issues because of that. The osteoarthritis, currently there's not much that can be done except for joint replacement, and that can work. Okay. We also have another dysfunction that comes about in joints with gout. And when somebody has gout, they have high levels of uric acid in their blood, and it starts to crystallize, precipitate out because of the concentration. And when that happens, you actually get crystals within the joint. And so when the joint moves, those crystals grind around and are very painful. So the treatment for gout is to reduce pain, or any of these arthritis, really. Try to reduce the amount of pain the person has, and then you try to get motion within the joint. In the case of gout, obviously you have to get the uric acid levels down, and there's a medication, allopurinol, that can be used to do that. In some cases, they can transplant cartilage to a joint. Sometimes this works. They may get better at that in the future. And then obviously I mentioned joint replacement. If you replace a joint, then you don't have that issue anymore. When we age, there are some unfortunate consequences with respect to bones. The bones and cartilage tend to deteriorate. In part, the cartilage deteriorates because of poor circulation. So cartilage can start to calcify, and the chondrocytes, that the living cells within the cartilage, die, and so the cartilage is no longer as supple. You've undoubtedly heard of osteoporosis. Osteoporosis is a condition that frequently occurs in older people. The bones become weakened, and so usually the treatment for that is to try to increase bone density by encouraging bone growth. You can do that with vitamin D supplements and calcium supplements. I should mention the calcium supplements, you have to be sort of careful about what kind of calcium you take, because a lot of calcium supplements are not soluble. These are not effective, and they won't help you out. But calcium lactate is a soluble calcium salt, and that's one that works pretty well. If you do activities that involve weight bearing, they can actually slow down or stop the deterioration of the bones and the cartilage. For homeostasis, the skeletal system is functional in a bunch of ways, and it has effects with other systems. So the skeletal system can protect a lot of organs. We gave the example of the brain being protected by the skull. We also see that the skeletal system is going to aid in respiration. So we're going to, when we talk about this eventually, the diaphragm is responsible for most breathing arrests, but when you're physically active, you use your thoracic wall and the ribs to help increase the exchange of gases between your environment and your lungs. Also, the bones are going to be active in red blood cell production, which is obviously going to have an important impact on the effectiveness of respiration. The bones can be associated with the production of white blood cells. They are, and so therefore they have an impact with the lymphatic system. When we chew our food, that actually helps us digest our food, and so the bones are involved there. Storage and release of calcium and phosphate. So I think we mentioned this, right? If you have too much of these materials, they can precipitate onto the bone. If you don't have enough, the bone can release them, and that can be helpful up to a point. The release is somewhat restricted. You can't have unlimited amounts of calcium and phosphate released from bones. So calcium is really important for a lot of different things: nerve conduction, muscle contraction, blood clotting, activation of various cellular activities, obviously the production of milk. Phosphate has maybe even more important involvement with ATP, adenosine triphosphate, ADP, adenosine diphosphate, AMP, adenosine monophosphate, DNA and RNA, and some of the buffers. The buffers are really a smaller role, but those other 5 organic molecules are really big deals. The chewing, actually we mentioned already, can help in digestion of food. Also, bones are pretty important if you want to move around. We use them as lever systems and as points of attachment for muscles, so we can move because of our bones. And so what if we have low levels of calcium? We have a feedback loop that can help restore the levels. The parathyroid gland releases parathyroid hormone. That in turn activates osteoclasts. The osteoclasts dissolve the bone matrix slowly. Then when that happens, the calcium is released and that goes into the blood, and then the higher levels of calcium in the blood inhibit the gland from releasing the hormone. So this is a negative feedback loop. What if we have high levels? And high levels, the thyroid gland gets involved. It releases a hormone called calcitonin. Calcitonin stimulates the osteoblasts to form new bone material. They do that slowly. And then the mineralization of the bone removes calcium from the blood, which in turn inhibits the release of the calcitonin, another negative feedback loop. Okay. So the integumentary system and muscles help with protecting organs. It's not all up to the bones. Gastrointestinal tract is going to help the bones out by absorbing calcium, and then plasma, the blood, is going to transport the calcium to the bones. The endocrine system is going to help us regulate storage and release of calcium. We just went through that. And it also helps regulate the bone growth. The cardiovascular system, obviously real important in maintaining an environment so that the bones can be alive and healthy. Movement is not going to be up to the bones alone. That's going to be involving muscles, and that actually is going to be the subject of our next PowerPoint. So this gets us through Quiz 6. We're going to be having that online. I have created the quizzes for that. There are a lot of questions in the database and the quiz pool that the quiz comes from. I hope you enjoyed this lecture. I hope you enjoyed Pansy's antics,
and she's gone into a coma, as is often the case. Okay, guys, wish you the best of luck with this material, and I hope you enjoyed the lecture.